When you think about businesses that are selling through the roof, like Skims or Allbirds, sure, you think about a great product, a cool brand, and great marketing. But an often overlooked secret is actually the businesses behind the business, making selling and for shoppers buying simple. For millions of businesses, that business is Shopify. It's home of Shop Pay, the #1 checkout in the world. You can use it to boost conversions up to 50%, meaning way less carts going abandoned and way more sales going through to checkout. Upgrade your business and get the same checkout Allbirds uses. Sign up for your $1 per month trial period at shopify.com/income, all lowercase. Go to shopify.com/income to upgrade your selling today. Shopify.com/income.
Hi everyone, I'm Deb Flashenberg. Welcome to Yoga, Birth, Babies, a podcast produced by Prenatal Yoga Center. We will be diving into everything prenatal yoga, birth, and baby related, hoping to inspire, educate, and empower you through your journey into motherhood. Thank you for listening.
Hi, I'm Deb Flashenberg, and I'm your host of Yoga Birth Babies, and we're continuing our series From the Vault. These are some of my favorite podcasts, as well as podcasts that I want to dust off and bring back. Some important topics that I want to have out there for you, our listener, to hear. So this one is called, Is That Normal? What to Expect from a Newborn. Newborns are fantastic, but they can be weird. They make some weird sounds. They've got some weird quirks and bodily functions. If you've ever watched a newborn sleep, their breathing pattern can seem odd, but Dr. Agnese, our guest, is going to talk about that and share what is within the realm of normal. We're going to talk about baby hiccups, baby snot, baby poop, all the fun things about babies. And we're also going to talk about warning signs. When is it really time to call your doctor? So let me tell you about our guest. So Dr. Tracey Agnese, she received her undergraduate degree from University of Delaware. She graduated from SUNY Downstate Medical School and completed her pediatric residency at NYU. As a pediatrician and mom, Dr. Agnese knows how difficult it is to care and have a newborn baby. She also knows that new parents often neglect themselves, and she wants to help change that. I'm really excited for you to hear this conversation. I think it can help demystify and help with the overwhelm of that freshly newborn period. So I'm excited for you to hear this conversation. Before we get to my talk with Dr. Agnese, I always love to give updates about the studio. And really the best way to find out what's happening within our classes and our workshops and our on-demand classes and our teacher training is head to the website. We have all that there, but we have some extra things there too. We have a lot of free resources. We have some free videos, some free yoga classes. It's funny, some of them are pretty old because there are some from when I was pregnant with my first child, and he's 13 now. So it's fun to see those, but they're still valuable. Hip work and back strengthening and shoulder opening, all that stuff is there. And then, of course, we've got the podcast and we have a blog there. I have been doing a blog for, I think it's like 18 years. So there's hundreds of blog entries. I used to do it weekly, but now I do it monthly. So there's a ton of free resources on our website. So you can head over there and grab those. And I think that's it. The last thing I want to say is if you have a moment, please take that moment and leave a rating and review for the podcast. It helps people find us. And yeah, I think I'll stop talking now. We're going to take a super quick break. And when we come back, please enjoy my conversation with Dr. Tracey Agnese.
The new McCrispy Strip is here. Dip approved by ketchup, tangy barbecue, honey mustard, Sprite, McFlurry, Big Mac sauce, double dipped in buffalo and ranch, more ranch, and creamy chili McCrispy Strip Dip. Now at McDonald's. Ba-da-ba-ba-ba.
Tracey, I'm so excited to speak to you again. Welcome back.
Thanks. I'm so happy to be here. Thanks for inviting me.
Yeah, as soon as I thought, all right, I want to talk about newborn procedures. Actually, my student said, Deb, do something about newborn procedures. I'm like, oh, I know who to call. So, because we had such a good time on our last podcast. I'll make sure I link to that in the show notes. But I'm sure I gave these questions to you before, so I'm sure you've got a ton to go off of. And so let's just dive in. All right. So in case anybody didn't hear your last podcast, which was wonderful, why don't you tell everyone a little bit about yourself and then how you decided to focus on pediatrics as well as become an IBCLC?
Sure. Yeah, absolutely. So I am Tracey Agnese. I'm a pediatrician in Manhattan on the Upper West Side, and I've been practicing pediatrics for over 10 years now. The thought of how I went into pediatrics is something, it's funny, I actually don't even really remember it so much anymore. As a kid, I always wanted to be a pediatrician, and I remembered actually buying stuffed animals at garage sales with my mom saying, I'm going to put this in my office one day. So I always wanted to do it. But then when I was going through rotations, I actually really liked OBGYN, considered that for a while, but quickly realized I didn't want to be a surgeon. And as soon as the baby came out, I was really interested in what was going on with the baby and not as much as with the operating kind of procedural stuff. So I don't know. I just love pediatrics. And I got into lactation because I had thought about it, just because the new mom comes here with the baby so often in those first few weeks of life, especially, but also the first month or two. And they're not really seeing anyone for themselves until about 6 weeks. And so they just have a lot of questions about lactation because feeding a baby is really the biggest thing on their mind in the beginning. And so I thought about, we don't get much education in that in pediatrics. And so I wanted to get more for myself. And then when COVID hit, I found really a need because nobody was really doing in-home, lactation consultants. So I just started doing it in my office, trying to help them out, because me helping them was better than no one. And then I got my, IBCLC.
I love that you offer that. I think it is so important. And I want to highlight that it's so true that a lot of pediatricians, even OBGYNs or midwives, they don't have a ton of lactation experience. And they don't have then the skills to support their clients. So I think it's such an amazing skill and advanced degree or certification that you have to help your clients. I think it's just wonderful. So those on the Upper West Side, go to Tracey. All right. All right. I'm here. So let's dive into newborn procedures. All right. I know there are a lot of them, so we'll try to be concise with them. Can you talk a little bit about the eye ointment that babies get? Why they get it? When it needs to happen, how much do they need? What happens if they don't have it? There you go.
Sure. Yeah, there we go. Okay. So the eye ointment, it's a prophylaxis, which is a term we use to say we're preventing something. In the United States, it is mandatory for all newborns. And we give it because it prevents gonorrhea infection in the eye of a baby. So it is, although that is a very rare infection, the eye is the most frequent site of infection in newborns, and it can cause really serious disease, including blindness. And the eye prophylaxis is preventing that is an eye ointment. It's called erythromycin eye ointment. So it's an antibacterial eye ointment. It's very easy to administer. You just put it across the baby's eyes. It's, not difficult. It doesn't really have any major side effects. And it can prevent blindness. So that's really the reason. And the, side effects could be a little irritation of the eye. If that happens, it usually resolves within a day or two anyway. Some people cite blurry vision as a side effect that they're opposed to, but newborns have blurry vision anyway. They don't really see too far. Things are blurry. So, to prevent blindness, I don't really think that that's something that should be that significant. And it should be applied as soon as possible within 2 hours after birth to prevent that. So that's why we do it. Pretty simple.
If it's for gonorrhea, would somebody know if they had that?
Oh, good question. Right. So it is totally possible. And this is a big part of it, that somebody would have gonorrhea and be asymptomatic, which means you have no symptoms. So, that is the reason. So you can have it. You can, it's transmitted very easily, and, you might not know you have it, and even if you got tested during pregnancy, it is possible that you would pick it up after testing and you have it and not know.
So, trying to think of some students that I know, I really don't want much to disturb that time right after baby. If somebody really felt strongly, could they be tested at like 37, 38, 39 weeks for gonorrhea and that be pretty accurate? Or am I just being too picky?
I don't know. I think it's being too picky for something that's really not a big deal. It's just a little like, ointment on the eye. It takes a second to do, and so, you never, if you missed, the infection somehow, if it wasn't there in the test, or they acquired it after, or there's a lot of reasons that, I don't know. I don't think it's a big deal at all, and it can prevent blindness.
No, I definitely want to prevent blindness. I guess I'm just trying to think of some students who are like, I want nothing. And so, I remember, my midwife, she's like, bloop, bloop. And she really put barely any in there. I think if I'm correct, New York state law, you have to do it.
You have to. Yeah. I think it's the United States. I think you have to do it. Yeah.
Oh, all of US. Okay. Curious. All right. So let's also talk about the vitamin K shot. Kind of same thing. Are there alternatives? Why do they get it? When do they get it? Can they opt out of it?
Sure. So vitamin K. So what is vitamin K? So it's a vitamin that helps your blood clot. The K actually, I just found this out, is a Danish word for coagulation. That's where it comes from. So it helps with coagulation. And, so it helps your blood clot. Vitamin K deficient bleeding, we call it VKDB. That's, a disease in babies. It used to be called hemorrhagic disease of the newborn. Hemorrhagic meaning bleeding out. So that's a condition in newborn babies where they can bleed uncontrollably because they don't have enough vitamin K in their blood. And that's what we're preventing. And it's not just easy bruising or bleeding, but this vitamin K deficient bleeding can be a very serious condition where the baby can be bleeding internally, like inside their body, and the bleeding, might not be noticed right away. They can bleed into their belly, into their intestines, into their brains, which can then cause brain damage and even death. So that's why that's the disease that we're trying to prevent. There's three different types of VKDB. There's early, classical, and late. I'll just kind of briefly summarize them because it helps to understand as we're talking about giving it and when and the kinds. So the early type it occurs within the first day after birth. This is usually, actually, I think almost always in babies whose moms had certain medications during pregnancy that makes them not be able to, it interferes with vitamin K. These are some anticonvulsants, so anti-seizure medicines, certain antibiotics for different things. So this is something that usually the pregnant mom would be aware of. The doctors probably talk to her about this is something that we're, looking out for, and they would be aware of that. But then there's the classical, and then there's the late vitamin K deficiency disease as well. The classical is about the first week of life where the baby bleeds from the umbilical cord usually. And then the late can take place in the first 6 months of life or even a little later. And this is often seen in exclusively breastfeeding babies because breast milk actually has very low vitamin K. Formula is supplemented with it, so you don't often see it in that. And this one is rare, but with a high frequency of intracranial, so in the brain bleed, and can be very serious. So those are the three different types. Why do newborns not have enough or really a lot of vitamin K at all when they're born? It's a few reasons. They're born with about 20%, I think, of the adult values, for a few reasons. One is they have immature livers, and that helps to, is synthesize and make it. So their immature livers is a reason. The second reason is that it doesn't transfer well from the placenta. So even if mom has adequate vitamin K, it doesn't transfer into over the placenta into the baby very well. And also, I mentioned vitamin K is low in breast milk, and newborn babies have a sterile gut or almost sterile where we get our vitamin K from foods we eat and bacteria in our guts, and babies don't really have that yet. So those are the reasons they are low in vitamin K.
So if someone
any questions on that? Yeah, I feel like I've been talking.
No, that makes sense. No, actually, I had not heard. That makes a lot of sense. I had not heard about the intracranial later in that 6 months. That was actually really something new and interesting. So I know it's given through a shot. If someone doesn't want that, what are their alternatives?
Okay,
or
so
are there alternatives?
So in the United States, there actually is no, or by alternatives, you're talking about oral, right? So
Yes.
the shot that we give is a shot in the muscle, of the baby. There is an oral version of vitamin K. There is not, one that's approved in the United States. But I think some places in Europe have it. And the problem is that it has been shown several times to just not be as effective as the shot. So it's not recommended, and it's just not absorbed as well, through the stomach and the intestines. So the shot really is the most effective one. The Australia, actually, there was a recent study that further supported the IM, which is intramuscular, which is shot, version of vitamin K, because Australia kind of recently changed their national guidelines from oral to the shot version of vitamin K, and that went with a significant decrease in bleeding afterwards. So that was just another recent one showing that the shot is better.
See, that's what I love. I just love that we can give information, and then parents can then also understand why these things. So I think one thing I've seen from some parents are like, why does my baby get a shot so right away? And I think if they can explain, it can then make them feel a little bit better, because sometimes babies cry from the shot.
Yeah,
and as a brand new parent, you're like, my baby's just born. So
one thing I want to mention, actually, with what you said, you were not being, aware so much of the later vitamin K disease, which can be the brain bleeds.
Yes.
The problem, and why this is so important for people to understand, is that in that later presentation, they don't have any really signs before they're very sick. So they'll just present with vomiting and seizures when there's already been bleeding in the brain. It's not like something that you can, pick up early and kind of intervene. At that point, that late one, it's very serious very quick. And that's actually kind of more of the thought, I think, behind why the shot is better than the oral, is that it's absorbed into the muscle, and then it kind of has delayed, release later on. So some of these oral versions that are given in different countries, there's various different, timing where they give it, I think, immediately after birth, and then they give it many times within the first few, weeks or months. And then, of course, anytime you are giving something orally, not only is it not as effective, but then you run into, administration isn't always exactly as ideal, and then that can further decrease the effectiveness of it too.
Yeah, I think about with my kids and antibiotics, if they have to have for 10 days, or by day 7, we're like, wait, did we do it? Did we not? Are we done? Where are we with
totally,
this?
Totally. And then even the vitamin D, it's hard to sometimes remember if you gave it that day or not. And, so
we would make a chart.
Yeah. So it's hard, with a newborn baby at home to remember to do that. So
I just think it's helpful for people to understand the why, so that should they be encountering something that maybe doesn't feel immediately great, they're like, okay, I get why we have to do this.
Yeah. And actually similar with that too. I don't want to go into all these crazy numbers, because I think it's, people don't, it's hard to hear, but just two quick things is that babies who do not get the vitamin K shot are 81 times more likely to have vitamin K deficient disease. And then 20% of those babies with it will die. And then the ones who don't die can have brain problem and, damage. So prevent something very serious. And the pain, is something that can be mitigated. There are things we can do. Every institution is a little different as far as, if they'll allow you to do the shot while nursing. But if that's available to you, that could be a great way, if you do choose to nurse, and they let you do it, a great way to mitigate the pain in the baby. And skin to skin also, is a great way. And I've actually seen babies not even flinch with it, because, it can be, they cry sometimes just as much with a underarm thermometer reading, because everything is they're hyper aware of everything, but it's not, it can be minimal,
Well, that makes me think about, I'm kind of jumping ahead on some of the things I was planning to talk about, but I want to jump into the timing. So you were saying that, you can wait till they're nursing, and how long can somebody delay things like the vitamin K shot or the eye ointment if they want to get a little undisturbed bonding time? What is
absolutely.
the rule for that?
So the vitamin K is supposed to be given within 6 hours. The sooner the better, but a few hours is usually fine. And the eye ointment is supposed to be within 2 hours.
All right. So that gives somebody, cause again, I'm only referring to like what I saw as a doula. It was pretty often baby came out and they kind of wanted to wrap things up. They're like, okay, let's get the eye ointment, let's get the K, let's get baby's weight. And it sometimes felt like, and I don't want to play good cop, bad cop, but like I kind of had to jump in and be like, can we have a little time? Because first, like, baby came out, we had some nice bonding, cleaning up the birthing parent, getting them all comfortable, and then right into it. And it certainly was not 2 hours. I'd say it was like half an hour. And sometimes we had to really push for like, can we have an hour? Can we just have a little bit more time? So what would you say to someone that really wants to take at least an hour to how to protect that time?
Yeah, absolutely. I mean, I think that the trend now is definitely across, is more towards, encouraging that immediate skin to skin contact, in, the hospitals that I've seen, around here. And I think throughout the country, of course, there's probably a lot of variations, but, that importance of the immediate skin to skin is very well documented. And I think most people are starting to understand more and more. So, of course, I have to say, because I'm a doctor, that in conditions where the mom and the baby are both medically stable enough to, allow that, where further urgent interventions aren't needed, then really most newborns should be able to be placed skin to skin, immediately, after a vaginal or a C-section. And during that skin to skin is when that first breastfeeding, if they choose to, should be encouraged. And that can have great benefits to, the baby, more stable vital signs like heart rate and blood pressure, improved blood glucose, which is the blood sugar during the first, few hours and days of life, increased, breastfeeding duration, even at 1 to 4 months postpartum, can support bonding with the parent and the baby. And it just encourages some of the innate breastfeeding behaviors in babies. So there's a lot of data out there for what saying you would like to encourage in your patients, which is that immediate skin to skin.
That is so great. So immediate skin to skin, as long as the parent and the baby are stable and fine. And so that means someone could push off the newborn procedures for like 1 or 2 hours.
A few hours. Yeah. I think that's, again, I think that's really the trend, is to be more accepted, to prioritize that, and then do the things like that need to be done, even, weighing the baby and, doing those interventions in a few hours is usually pretty fine.
Oh, good. I actually want to talk about weighing the baby. We're going to take a quick break. And when we come back, we're going to talk about baby's first weight. We'll be right back.
Summer's here, and you can now get almost anything you need for your sunny days delivered with Uber Eats. What do we mean by almost? Well, you can't get a well-groomed lawn delivered, but you can get a chicken parmesan delivered. A cabana? That's a no. But a banana? That's a yes. A nice tan? Sorry, nope. But a box fan? Happily, yes. A day of sunshine? No. A box of fine wines? Yes. Uber Eats can definitely get you that. Get almost anything delivered with Uber Eats. Order now. Alcohol in select markets. Product availability may vary by region. See app for details.
Ryan Reynolds here from Mint Mobile. I don't know if you knew this, but anyone can get the same premium wireless for $15 a month plan that I've been enjoying. It's not just for celebrities. So do like I did and have one of your assistants switch you to Mint Mobile today. I'm told it's super easy to do at mintmobile.com/switch.
Upfront payment of $45 for 3-month plan, equivalent to $15 per month required. Intro rate first 3 months only, then full price plan options available. Taxes and fees extra. See full terms at mintmobile.com.
All right, so let's talk about baby's first weight. So something that I learned about 7 years ago on one of my earlier podcasts was when someone has an epidural, we know that they have to have continuous fluid, IV fluid, because an epidural can make someone's blood pressure drop. Now, when the birthing parent's having that fluid, their body's taking it in, but also what I learned is that babies' weight can be artificially inflated because of all that fluid. And something my own pediatrician I had a conversation about was taking consideration, because I know that sometimes babies then have to pee it out. Not sometimes, they pee it out, and then there can be that drop in weight. And it's like, oh my God, baby lost too much weight. So when does a baby get its first weight taken? And do you think it's generally taken into consideration how the baby was born, if it was with an epidural or without, because of that weight drop?
Yeah. So usually the first weight is either immediately or within, first few hours, either in the birthing room or maybe in the newborn, afterwards. It's usually pretty soon. Are the fluids taken into account with the weight loss? Honestly, usually not, because we're often not seeing all those records of how much fluid was actually given. But what we do take into account is not just the birth weight. And I guess I'll just back up a minute just to explain to all the listeners what we're talking about is that most babies lose weight after birth. We generally accept and allow them to lose up to 10% of their birth weight. We like to see them start gaining the weight usually around days 3 to 5 of life, which usually coincides with milk coming in if they are breastfeeding. And then we like to see them get back up to their birth weight by about 2 weeks of age. But that 10% isn't the only thing that we look at. We also look at how feeding is going, the number of wet diapers, the stool number, and the consistency of the stools, which is the poops, and jaundice, right? So for example, if a baby is over 10% of their weight loss, but is feeding really well and having a lot of wet diapers, meeting the daily wet diaper requirements, is pooping a lot and the poop is getting waterier and yellow and seedy, and the baby's not jaundiced, and we might elect to carefully monitor for a day or so and see if that baby then, starts to increase weight and not be 10%, starts to go in the right direction. But similarly, if the baby hasn't lost quite that 10%, maybe baby lost even only 5 or 6%, but the baby isn't feeding well, isn't meeting the number of wet diapers required per day, is not stooling in a little while, or the stool is still really thick and closer to meconium, or the baby's jaundiced, then we might be concerned sooner, even if they haven't gotten to that 10%. So we do talk about that 10% a lot, but it's a little nuanced and it's not, so black and white, and we like to think about all the things.
I love that you take so much more into consideration than just the numbers. I think that's really important. But when are doctors seeing this? So in general, someone can be in the hospital for, it depends on the kind of birth and where. I know, when we had a birth center at Mount Sinai West back in the day, I know it makes me sad. It was a different conversation.
So sad, I know.
They would be out within 24 hours, but then if they're in L&D, maybe a day or two. If they had a cesarean, up to 3 days. So if someone had a hospital birth, when are they seeing the pediatrician to keep all this in sight, as well as it may not be their pediatrician they see once they leave the hospital?
Right. Yeah. I used to do newborn nursery rounds in the hospitals. We used to do it at 2 hospitals, and then with COVID we stopped and we just didn't go back. And again, I think that is also really the trend across the country, is that the outside, private pediatricians are kind of leaving that to the hospitalists who are, the newborn hospitalists. So most of the time it's not going to be your pediatrician who's seeing the baby in the hospital. And that's fine. They're amazing. And that's what they do. They do newborn, exams, in the hospital. So, now it's usually, if it's a uncomplicated vaginal delivery, you're in the hospital for maybe, a day or two. If it's a C-section, maybe 2 or 3 days. And it used to be, 2 days with the vaginal, 3 with a C-section, but, kind of a little shorter now, maybe sometimes with the pandemic. And then we are seeing the babies in our office. It's usually anywhere from 1 to 2 or 3 days after they're discharged. So it might be the next day, especially if there were concerns about feeding or weight or jaundice, it's usually not much later than 2 or 3 days after being discharged.
That's good. I still remember carrying we lived 2 blocks from our pediatrician, and I just remember being like, the baby is so small to take outside. It was just so crazy bringing this teeny baby into the doctor's office. But oh my gosh.
I have so much to say about that. I think that there's other countries that do such a great job of providing that, dyad care in the home. And I wish we can kind of head that way.
It's a whole other conversation, but I hear you. I hear you. I actually had, I had a midwife, and she came to see me at home, and it was pretty amazing. I mean, she checked on the baby, obviously, but to have somebody come into my home within a few days of birthing, and then I would she'd have me check in with her every single day for, I think it was like 3 or 4 weeks, just like a phone call. Just like, how are you? And that's so lax in our care.
I actually know a kind of a group of pediatricians who, and I think a mix of pediatricians and some OB/GYNs with it too, who are providing, 4th trimester dyad care in the home through usually it's a direct primary care model, where they go and do this. And I just wish that's something that's accessible to so many more people.
I know, because between leaving the hospital and seeing a care provider, 6 weeks when we know that is just a time for things to kind of fall apart. All right, let's pull back to newborn procedures.
Yes, I know. We could have another whole discussion on that.
All right, so delayed cord clamping.
Yes.
So how long can someone delay cord clamping, and why would someone want to wait?
Yeah. So delayed cord clamping is also kind of more of the normal at most hospitals now, where historically doctors used to clamp the umbilical cord immediately after delivery of the baby. And, just a reminder, the umbilical cord is connecting the placenta, to the baby, and immediately after birth, the placenta is still inside the mother, and then that detaches from the uterus and is delivered afterwards. So delayed cord clamping means where you're waiting to clamp the umbilical cord, and therefore you are allowing extra time for the blood in the umbilical cord and the placenta to flow to the baby. It actually started about 10 years ago. I think the research really showed that premature babies benefited the most from this additional blood volume from the placenta. So it became common practice with premature babies first. And then the research, came out that full-term babies also really benefit. So the American College of OB/GYN, ACOG, and the AAP endorses it as well. They recommend delaying the umbilical cord clamping for all healthy term, infants and everyone for at least, they say 30 to 60 seconds after birth. And then the World Health Organization says to wait 1 minute. Some other groups say it's okay to wait 2 minutes or a little longer. But I don't know, honestly don't know the data on that. I do know that the minute is really beneficial, and most of that benefit comes from the minute. I guess I could talk about the benefits, right? So why are we even, so more blood means more red blood cells, means more iron, which means less iron deficiency anemia, not only at birth, but actually, delayed clamping can improve the iron stores for several months in the baby, which helps prevent this iron deficiency during the whole first year of life. So, since iron deficiency can be linked to impaired or, brain development, or, you're basically helping to improve and maximize the infant's cognitive, motor, behavioral outcomes by doing this. In the premature babies, they saw initially that those babies who had the delayed clamping had increased oxygen levels in their blood, increased survival, less need for blood transfusions, and lower rate of some serious complications. So
I think it's a great trend. And it's not
I know. Me too.
What's been interesting is, I've had prenatal yoga center for 20 years, so I've seen different trends come and go. I'm thrilled that delayed cord clamping is now has data supporting it. But what I've noticed is I used to get emails all the time from blood banks, be like, oh, we'd like to sponsor and do this. I don't hear from them anymore. So I'm wondering if cord banking is not as popular, since data is showing delayed cord clamping is good for the newborn. And if it's going into the newborn, it's not getting banked. Have you noticed that shift?
Honestly, I haven't, I don't see that as much because I'm not really there, but that definitely is, there's less blood to bank if you are, if you're giving it to the newborn. Yeah. But I know I'm okay with that. I'm always more of a proponent of the blood banking in the, general big central registries, if that's something, that the parent chooses to do, because, the benefits to the actual baby from cord banking are very minimal. I mean, I've talked to a lot of doctors about this because I've been quite curious, and there's usually not really much of a reason to do it. So the benefits of actually the baby getting that blood
far outweighs.
To me far outweighs this potential that usually for the most part you're not going to be using that for that same person anyway. It's really more of like maybe a sibling if you have a known familial condition where but again the general bank is, I think, usually what I recommend. But But the risks to that baby in that moment the benefits are clear. They're there.
Yes, delayed cord clamping. I love
There is
that.
one risk I should mention, though, I guess, while we're talking about that is less blood to bank. But the biggest risk is, as far as my end as the pediatrician, is the increased incidence of hyperbilirubinemia, which is jaundice, which is when babies are a little bit yellow. Because jaundice is too much bilirubin in the blood. Bilirubin is a normal byproduct of the breakdown of red blood cells. We all have it. You and I, adults, we all have it. And then our bodies get rid of that bilirubin so it doesn't become too high. Babies don't do a great job of getting rid of it. They also have extra it being produced in their body as well. So with more blood from the placenta into the baby, that's just more of blood that can become bilirubin, so there is about a 40% increase in newborns needing phototherapy for jaundice with the delayed cord clamping. But that doesn't concern me because phototherapy is the lights, and that's a treatment for jaundice, and that is very effective. And that, we intervene with that before there's any damage to the baby. So, it's something that, I still think is really a benefit to do.
Yeah. I think a lot of this is just outweighing the risk versus benefit and seeing what someone feels most comfortable with.
Yeah. Which is like life, right? And we learned anything over the last 2 years too. That's really what life is about, right?
It is.
Weighing all the risks and benefits.
So let's talk about, if we're still on newborn procedures, when does baby get their first bath?
Sure. Yeah. Again, I think I've seen this even in my practice over the last, 10 years where, it's been, it used to be immediate and now it's, a little later in most places. Although I looked into this because they actually recently did a nationwide survey of hospitals to see what hospitals are doing. And there's a wide variety of approaches. So most hospitals, they quoted around 60%, 63% delay the bath for about 6 to 24 hours after delivery. And with the exception of like drying the infant initially, another 15% wait until 24 hours and, just 8%, do it within 6 hours after delivery. The World Health Organization recommends delaying the first bath until 24 hours, but at least 6 hours if a full day isn't possible. So the U.S. hasn't really implemented this recommendation into any standard protocols. That's why we see such a variation, I think, nationwide. But yeah.
So if someone wants to delay, they have every reason to. If they
yeah, there's benefits. Yeah.
The vernix that you can kind of rub into their skin.
Yes. Absolutely. Yeah. I mean, that vernix, so that's what the baby's covered with, in utero. It's like this waxy white substance coats the baby's skin, and it's really amazing. I mean, it has properties that we don't even probably know all of them yet, but even what we know is amazing. It's a natural moisturizer, has antibacterial and cleansing properties. It can help with wound healing and temperature regulation. So keeping that on is really very, very good for the baby.
Yay. All right. So we're going to talk about the APGAR.
Sure.
I've had parents be like, my baby's APGAR score is fantastic. I'm like, it's okay. It doesn't mean it's their first test score. So
yes, I know.
It's not going to get them into grad school anywhere. It's okay. So what is the APGAR? What is it? Why do parents want to know about it? What does APGAR even stand for? Why should they be concerned?
Yeah, sure. Okay. So your APGAR score it's just a quick way to assess the health of a newborn baby. It's actually funny because I looked into it, and so it was created by a Dr. Virginia APGAR. Her last name
Don't you find that hilarious?
I find it, well, yeah. So I just think like
it works.
It is. And I don't know how does it work? Because it's spelled APGAR, right? So we use it as an acronym that stands for A is appearance, P is pulse, G is grimace, A is activity, and R is respiration. And it's just incredible that this woman who created it has a last name that you could do that with. I think it's amazing. I know. I'm glad it makes you laugh as much as me too, because I think it's amazing. Yeah, so each of these 5 things that the APGAR stands for is scored on a scale of 0 to 2, with 2 being the best score. So this is measured. We give a baby a score. We add them all up. We measure it at 1 minute of life and 5 minutes of life. So and then we get a number, right? So 10. There's 5 things. The highest is 2. So the highest APGAR score you can get is 10. It's always a joke actually in the hospital. It was always a joke that the only babies who actually get a 10 are pediatricians' babies because they're worried about it or whatever. But most babies don't get a 10. 7 or above is really considered totally normal. And most babies don't get a 10 because most of the time their hands and feet are a little blue and they have to be warmed up, and that's fine. So 90% of babies have this normal above 7 or higher, APGAR score. Lower scores mean that the baby is more likely to require some medical intervention, such as stimulation or oxygen or breathing assistance or medications or chest compressions. And so again, I guess I can just say briefly, the A is appearance. So we look at the skin color. Is it pink? Is it blue? Does it look, that there's a good blood flow to it? P is the pulse, so that's the heart rate of the baby. G stands for grimace, which is a grimace response, which is the reflexes of the baby. A is activity, so like the muscle tone of the baby. R is respiration, so that's the breathing rate and the effort.
So good. So parents just know it's probably not going to be a 10-10. It's okay.
No, it's not going to be a 10-10. And really, outside of that immediate newborn period, no one even really cares about it. Yeah, no one cares about it.
And it can be done. It's by sight. So baby doesn't have to leave to have this done.
Absolutely.
It's right there on the parent's chest, happily snuggled in for some skin to skin, which I get. I'm so glad that you're such a supporter of skin to skin. So we kind of touched on this earlier about initial breastfeeding. I have seen some babies like immediately rooting for the nipple, and then I've seen some that seem not to have interest. I've been told by IBCLCs, wait for the baby to have that rooting instead of just shoving a nipple in their mouth. What are your thoughts on what to look for and when to start?
Yeah, I think, so birth is a stressful event, for the birthing parent and the baby. And as with any stressful event, you sometimes you get a little bit of energy surge, like right afterwards, so, and then you get like really tired and pooped out and you just want to rest. And that's kind of what babies do. So I do recommend to try to take advantage immediately after birth, in that first hour or two to try to get the baby skin to skin and try to get that first breastfeeding if if you choose to do that. Because then sometimes they just get really sleepy and really tired for a little while. It becomes hard to wake them up. And then if it's hard to wake them up, it becomes hard to get them to latch. And so try to do it, in the first hour or two. That being, and of course you hear stories and I've seen it where, baby, all goes well and the baby, all of a sudden starts kind of doing that crawl up to the breast and latches on. But I hate kind of telling that sometimes because then when it doesn't go so perfectly, then a lot of, new parents get so discouraged. But I think really more the norm is to have, some difficulty trying to get the baby on for the first time. And that's okay. Baby and you are both learning how to do it. So, it's just your first of many tries, but there's so much benefit to trying right away. So go for it, but not to get discouraged if it doesn't, seem as easy and, wonderful the first time that you do it.
It's definitely a learned skill, I would say, for most people.
For most people, I agree.
All right. One of the last things I want to wrap up with is the PKU test. Mm-hmm. Let's talk about it. When's it given? Why is it? What is it? I just remember seeing him like, you're doing what to the heel? How much blood?
Yes. So the PKU test, it's a newborn screening test. It's a blood test. And there's actually, it's one of the 3 kind of newborn screening things that are done in the hospitals now. So the PKU is the blood test. And then there's also, congenital hearing, loss screening tests and congenital heart disease screening tests. But I'll answer your question about the PKU, which is the blood test, right? So it's every state is different as far as what exactly it tests for. It is required in every state, but there's it varies as far as which specific disorders are screened for from state to state. But in general, it's dozens, sometimes 40 or 50 different diseases. Usually these diseases are very rare diseases, but they are ones that have little or no symptoms at first, but then become threatening to the life or the long-term health of the baby. And it's usually something that, if known about, you can intervene earlier to do something that can be life-saving or, improve the baby's life. So it picks up various different metabolic or genetic or infectious diseases, before their symptoms. What's usually done is the nurse will use maybe put a warmer on the baby's heel, because when the skin is warm, the blood flows much easier. And so they'll do that first, and then once the heel's warmed up, they just do a small poke to the baby's heel, and then they put drops of the blood onto this special paper which has like circles on it, and they have to get the blood into the circles. It does look crazy when you watch it. And of course the baby's crying because, you know, it is a little poke, and it does hurt a little bit when it's poked. But then also they, you know, you're holding their heel, and they don't love that. There's a lot of reasons they don't love it, but you know, a few drops of blood, they send it off to the state, and you usually get those results back within about 2 weeks. And then you can pick up something that, you know, you might really need to know about your baby.
I think it's really important. And what I didn't know, and thank you for enlightening me, I didn't know that it was different state to state, what they test for. That's really interesting.
It is. Yeah. Yeah.
And then you had mentioned 2 other screenings, the hearing and the heart.
Mm-hmm.
Can you explain that?
Yes, of course. So the hearing test, there are 2 different ones that each hospital uses. You might use one or the other. So a common one is the OAE, we call it. It's basically a soft little earphone that's inserted into your baby's ear canals, and the presence or absence of sound waves, you know, generated by the hair cells of the inner ear, in response to a sound stimuli. That's what's measured. And so you can, you know, pick up if there's hearing loss. Another test is similar. It's called the ABR, and the baby wears these small, like earphones almost, that has electrodes, and that are placed on the head. The electrodes are just like little stickers. They come off easily. It's not painful. They're painlessly placed on the baby's head. And again, we're also measuring some waves with this. So, and you can pick up hearing loss. Now, sometimes the babies, fail, quote unquote, I hate using the word fail, but they don't pass their hearing screen initially. And usually that's most of the time it's fine. It can just be because some of that wonderful vernix or, you know, fluids from labor and delivery are still in the ear, and interferes with the test. So usually it's just repeated, in, you know, either at the pediatrician's office or at the hospital, or somewhere for, within, you know, the first few weeks. And, you know, oftentimes the baby then, you know, passes and everything's fine. But if, you know, it is something that, you know, the baby is, it has difficulty hearing, then it's good to know about sooner than later, because then you can, you know, intervene if you choose, and, you know, increase maybe the, you know, development of the baby, earlier. So that's the hearing. And then the second one is the critical congenital heart disease screen. This is also a very simple, painless test. It measures the oxygen saturation, in the baby. So it's just, you know, if you've ever, you know, that little thing that they like put on your finger at the doctor's office, which tells you if you have what your oxygen percentage is. It's a similar kind of thing. So they measure it in the baby's right hand, and then usually, one of the feet, and just making sure that the oxygen's getting, everywhere equally, and making sure if there's a big disparity, then there might be a concern for a congenital heart disease.
Oh, this is such useful information. I love this. All right, we're going to take a quick break. When we come back, what is one final piece of advice or tip you would like to offer new and expectant parents? We will be right back.
Whatever the occasion, effortless elegance is right this way. Because Hilton brings you new ways to stay courtesy of the Nomad London. And it doesn't stop at award-winning dining in a space draped in velvet and illuminated by vintage chandeliers. No, this day goes beyond with unparalleled personalized service and attentive hospitality. Oh, and did we mention the Nomad London can be booked using your Hilton Honors points at Hilton.com? Hilton, for the stay.
All right, what do you want to hit us with? You gave so much great information, but you are also a pediatrician, a parent, and a lactation consultant. So what would you like to leave people thinking about?
You know, it's funny. I don't even know what I said last time. I'm curious. I'm going to have to go back and listen. But I would say I would love to people to just know that you're doing great. Because, you know, that's the new parents just question that so much. And it's a learning curve for both you and baby. But, you know, you're enough. You're more than enough. You're doing great. And just, you know, keep at it. And you're doing a great job, because I don't know, you are. And I think most people just, you know, question that and they don't need to. You're doing great.
Oh, I do love that. I love that. It's a great reminder, because how many times do new parents, and I know, I remember thinking this, I'm like, we just got to keep keep the baby alive. That's our job, is keep the baby alive. And it's overwhelming. It is so overwhelming to have this newborn, and most people don't have a lot of people around to help. So yes, I love that you're doing great.
Yeah, it's difficult. I know.
Where can people find your work?
Sure. So on social media, on Instagram, I'm baby.mama. And I also have a website, traceymd.com, TRACEYMD.com.
And for those that are listening, she's on the Upper West Side.
And yes, in my private practice, yes, in person, in real life, I am on the Upper West Side in New York City, general pediatrics practice.
Oh, I love this. You had such great information. And our last podcast, I believe it was called, I'm going to totally butcher it, but it's like weird things newborns do.
Yes, yes. Scary, weird things, that they do. Yeah, that freak out parents that are normal.
Like when they stop breathing for a moment, you're like,
yes. I like that one.
So this one was more like serious about know what they're doing. And that one was like, really, babies are strange. So I'll make sure. They're like little aliens in the beginning. I'll make sure that we link to that so that people can just keep learning from you. I wanted to thank you. I know I'm taking time out of your busy day at your office. So thank you for sharing all this great knowledge.
This has been an episode of Yoga Birth Babies, produced by Prenatal Yoga Center. You can catch us on Facebook, Twitter, Instagram, and Periscope. I'm Deb Flaschenberg. Thanks for listening.